Assalamu alaikum, good morning. So, I'm going to be discussing systemic parasitic infections, and we are going to consider two parasitic agents. By the end of my discussion, I expect you to be able to discuss the two parasitic infections in terms of the epidemiology, the biology, and the vectors of the parasites, how a patient presents, how you make a diagnosis, and management, as well as prevention and control. So the two conditions we're going to discuss is Chagas disease, or American trypanosomiasis, and leishmaniasis. So we start off with leishmaniasis, and if you still remember from your POD group, we have parasitic infections that are of public health significance, and according to the WHO, about 2 million new cases of leishmaniasis occurs annually, and out of this, about 1.5 million is due to cutaneous leishmaniasis, and about 500,000 is due to visceral leishmaniasis. We're going to find out what this means in a moment. In total, it's estimated that about 12 million people are infected worldwide. Now, when we talk of parasitic infections or vector-borne diseases, malaria is top on the list, right? Followed by lymphatic filariasis. Then we have leishmaniasis. So it's a significant disease. And the vector of this parasitic agent is the sandfly. It can either be the phlebotomous species or the lutomyia species. We'll come to that later. Now, in terms of presentation, you can have different presentations, and you have local names for these presentations because these are endemic diseases in usually poor, disadvantaged areas of the world. Okay, so you have things like Kala-Eza, which I think is Hindi for black fever, and it's an example of a visceral leishmaniasis in terms of what is going on in the patient. So VL stands for visceral leishmaniasis. It's also referred to as dum-dum fever because of the military barrack that was, the first site that they were able to identify this parasitic agent. So it's also referred to as dum-dum fever. Again, it's a term to describe visceral leishmaniasis. Some call cutaneous leishmaniasis white leprosy, okay? Because of the disfiguring lesions that is associated with this clinical presentation. Then you have Espondia, this is Spanish, I think, and it's describing the mucocutaneous leishmaniasis. Then you have others like Pen Boys, this is French, Chiclero ulcer, Utah. So different terms referring to different clinical presentations. Now it's becoming an important parasitic infection that you should think about because environmental factors that lead to climate change is enhancing the global spread. Remember that with vector-borne parasitic infections, if you don't have the vectors, you don't have the infection. So now that the temperature is changing, it's more conducive for the insect vectors. You now have them encroaching into areas where you don't normally find them. As a result, the disease follows, and you now have incidents in areas that were, not noted to have this condition. Like I stated earlier, it's one of the neglected tropical diseases, and it affects mainly the poor in low to middle income countries. Now, there are two important causative agents of visceral leishmaniasis. I'm singling this out because it's the most deadly form of infection. visceral leishmaniasis, and it's associated with usually these two strains, Leishmania donovani and Leishmania infantum. You have the epidemiology, so you have the world map, and the different presentations. As you can see, it's color coded, and you can look at these regions on the world map. Like I said, the vectors determines whether you have the parasitic infection. If you don't have the vector, you don't have the parasitic disease. So with Leishmania, you have both the phlebotomous fly as well as the Lutzelmeier fly being responsible for transmission. So I've only shown you the map showing, the spread of Lutzelmeier. So in this region of South America, you have this agent or this vector present as the predominant vector of transmission. Whereas if you look at Africa, if you look at part of Middle East, is the phlebotomous fly that is responsible for transmission of the pathogenic agent. So transmission and pathogenesis, you still recall from your POD lectures, so I'm not going to go into details, but remember that it's an indirect life cycle. You have the insect vector and you have the human host. And it's usually the female sandfly that comes for a blood meal because the heme in blood is needed for maturation of eggs. The infective stage is the promastigot, and once this is introduced, they become amastigot. The promastigots are motile, but the amastigots are non-motile, and they are usually found within macrophages or monocytes. Now, once they are ingested by these immune cells, they now use the immune cells to develop, divide, and spread to other sites from the site of inoculation. So the process of the mastigots dividing within the macrophages or the monocytes is a repeated cycle until eventually the macrophage breaks down. It's picked up by new macrophages and the entire process is repeated. Okay? Now, the process of breaking down the macrophages is associated with some immune response from the host. So how does the patient present? 3 clinical presentations. Situations in which the lesions are limited to just the skin, okay? You have situations in which the lesion is not limited to the skin alone. You now have involvement of mucosal surfaces. And then you have those in which it's more or less a systemic infection, where deeper organs and tissues are involved. Now, the most benign in quote is the cutaneous form because the lesions are limited to the face, to the skin. But the mucocutaneous and visceral are relatively more virulent. With the mucocutaneous, you're going to have disfiguring lesions that destroys the nasal septum, the cartilage of the nose, or the palate, depending on where the lesions are situated. With the visceral, internal organs such as the spleen, the liver, the bone marrow are invaded. So these organs can no longer subserve the function that they're supposed to subserve. So here you have pictures of the 3 clinical presentations. Let's look at them in details. Now, with cutaneous leishmaniasis, like I said, infection is limited to the skin. Usually it starts from the dermis, but eventually you have involvement of the epidermis. That's when it becomes an open sore. It's associated with these strains of Leishmania parasite. Then, like I said, the mucocutaneous. It's also referred to as nasopharyngeal because at times in some patients, the lesion is going to involve the upper lip and the nasal septum. Okay? And it's usually associated with Leishmania brasiliensis, subspecies brasiliensis. From the initial skin sites where the parasite was inoculated, it appears that it moves rapidly to the nasopharyngeal or palatine mucosa surfaces, and it may remain dormant for months to years, and then you now have rapid development with destruction of the nasal septum and surrounding lesions. With visceral leishmaniasis, like I said, you have involvement of deeper tissue and organs. As you can see in this patient, the marking is showing you the extent here, the extent of the splenic enlargement. So that's the spleen markedly enlarged. So the condition is usually associated with Leishmania donovani and Leishmania infantum. The parasite moves from the site of inoculation, multiply in reticuloendothelial cells, particularly those of the spleen, the liver, lymph node, and the bone marrow. So clinical cause is accompanied by marked hyperplasia of the spleen, as shown in this patient. And there is progressive emaciation. The entire abdomen is filled up by the spleen, so there is no space for food, so they can hardly eat, and they tend to present with progressive emaciation accompanied by weakness. So you have the history, you saw the patient, the lesions, you can identify the lesions now if you see a patient with this condition. But how do you make a diagnosis? Because at times, when you look at the skin lesions, it can be similar to what you have with Shagoma with trypanosomiasis. Okay? So how do you make a diagnosis? There are different approaches depending on how robust your laboratory backup is. In the high-income countries where you have the money for these highly sensitive tests, you can go ahead to culture. We have selective media for this organism in the lab. Usually when we subculture, we get the pro-mastigot stage. Okay? You can also use different nucleic acid amplification assays like polymerase chain reaction, LAMP amplification, and other molecular assays. Serology can also be used. So there are kits, which is a good thing because you can use this in the field in low to middle income countries. These kits can be stored at room temperature for some of them. Others you may need to store in the fridge or whatever. So we have, rapid diagnostic kits that you can use to make a diagnosis. However, these rapid diagnostic tests, they are not useful when you want to follow up after treatment, whether there is clearance of infection. So you cannot use it as a test of cure. And that's because the antibodies persist for a very long time. Even when the patient has recovered completely, responded to therapy, the antibodies persist for a very long time. Okay? So the serological tests, they are cheaper. You can use them in the field. They're relatively sensitive, but you cannot use them to follow up on the patient's management. Microscopy, that's about the cheapest of all the diagnostic tests that you can use. And with stain, it could be a bone marrow aspirate, it could be a splenic aspirate, although that is not encouraged because you can have bleeding that can be difficult to control because of the enlarged size of the spleen. But whatever sample you send to the lab, whether it's a biopsy, whether it's fluid from the lesions, you can send it to the lab and we can stain, and we look out for the amastigotes within the mononuclear cells. Is that clear? I want you to note that with leishmaniasis, you don't have the amastigot changing back to the trypomastigot stage. So we'll discuss that when we discuss trypanosomiasis. Additional tests that you can use include antigen detection tests, and these are suitable on urine sample, on blood. So even when you don't have biopsy specimen or aspirate specimens, you can still make a diagnosis. And these are particularly useful for monitoring treatment because it's the antigen associated with the organism. If you are able to clear the organism from the system, then the antigens are not there. This is in sharp contrast to the antibodies. The antibodies will persist for a very long time. Is that clear? Now, in terms of diagnostic samples that you can send to the lab, remember that you can have different presentation. You can have cutaneous, mucocutaneous, you can have visceral. So it depends on how your patient presents. For cutaneous and mucocutaneous, you can send in skin scrapings, biopsy, or aspirate from the lesions on the skin. For visceral leishmaniasis, splenic aspirate, although it's not encouraged, but you can, if it's safe to obtain the sample, you can send it an bone marrow aspirate or lymph node aspirate, depending on how the patient presents. So what's the approach to treatment? The treatment of choice for visceral leishmaniasis is systemic because this is a more virulent and it's a systemic disease. So the use of liposomal amphotericin B, particularly in India, is encouraged because, it's been shown to be safe in that population of people. Then we have miltefosine as an oral agent as a secondary choice when you have systemic visceral leishmaniasis. There are other drugs that you can use for mucocutaneous. For example, you can use sodium stolbogluconate. Amphotericin B can also be used. Treatment of cutaneous is dictated by the severity of the lesion, so the disease may be treated locally. Cryotherapy may be used, topical paramomycin, or systemic therapy. So how do we prevent infection? Remember, it's a vector-borne disease. So if you control vectors, you're going to control the prevalence of infection. If you prevent yourself from being bitten by the phlebotomy fly, then you prevent infection from occurring. So eradication of the vectors breeding sites near urban and suburban centers. Pyrethrin impregnated collars for domestic dogs because domestic animals, pets can be vector reservoirs. So when you treat the patient and the patient goes back and the dog that is a reservoir is bitten, then the whole cycle is repeated. So you can have animal reservoir in this case, particularly dogs. Sleeping under insecticide impregnated bed nettings can help. Now, we don't have vaccines for prevention. So we move on to American trypanosomiasis. It's also referred to as Chagas disease in honor of the medical doctor who described the condition. It's American trypanosomiasis because the arthropod vector is found in Central to South American countries. Okay? The vector is the Redovi bug. You still remember from your PhD lecture. Also referred to as the kissing bug because it tends to bite on the face, where you have high CO2 concentration. It's also referred to as the triatomy bug. Okay? Chagas disease is also another example of a neglected tropical disease. And the etiological agent of Chagas disease is Trypanosoma cruzi, which is an example of an hemoflagellate. And you know what that means. it's motile. It's a motile organism. It moves by flagellum, and it's a protozoan parasite, so it's unicellular. Now, in terms of the epidemiology, I want you to have a look at the map. You find out that it's endemic in most of the South American countries, right? And it's a bit of the Central American countries. Then you have non-endemic but present, because you can have movement from endemic areas into these parts, so Canada, the US. And then you have other parts of the world where there is no data as to the presence of the vectors. Now, according to WHO, about 6 to 7 million people are infected, and they're mainly in Latin American countries. And the death associated with this in a year is over 10,000. And the leading cause of death is usually cardiomyopathy, which is a complication of the chronic disease. We are going to discuss that in a moment. Again, the life cycle. It's indirect, right? But remember that in sharp contrast to other vector-borne parasites that we've discussed in the past, transmission is not through inoculation, but rather the infective stage is passed out in the feces of the arthropod vector, and then the host will rub it in. Always remember that point. It's one of the common board questions, all these USMLE questions, okay? So remember that transmission is not through inoculation. It's not through the bite of the vector, but through rubbing in access to the bite wound by the infective stage. And the infective stage is the metacyclic trypomastigote. Okay? So, in terms of transmission, the vector-borne route is the most common mode of transmission. Then you can have in endemic areas where you have fresh whole blood being transfused and it wasn't screened. It's a known mode of transmission as well, because you know you have the trypanosomes. During the active phase, they are present in blood. Organ transplantation, because remember that the organism can stop replicating, become tachyzoids, not actively replicating, brady, as in reduced division. So they are within the tissues. So once these organs are transplanted and the patient is now placed on immunosuppressive therapy, you can have reactivation and then they start, replicating. You can also have congenital transmission, particularly if that pregnant woman is being infected for the first time in that pregnancy, because you're going to have a high level of parasitemia, which can cross the placenta to the developing child. There can be oral transmission through contaminated foods and drinks. When you go to endemic areas, okay, most of the time when you have sugarcane-based drinks, because the arthropod vector can hide within the sugarcane plants, and at times when the drink is being squeezed, they can actually squeeze the vector, express the infective form, it gets into the food, and then it's consumed. Okay? So when you travel to these areas, it's better, remember what I told you in travel medicine. Boil it, cook it, peel it, or forget about it. So I think we've said this. Parasite present in the vector's feces are rubbed into the human host, through scratches and the bite wounds, or at times through mucosa, especially when it's close to the eye, so through the conjunctiva. So the trypomastigotes invade the host cells and they transform to A mastigotes, which replicates, eventually leading to lysis and inflammation, similar to what we have with Leishmania species. However, similar to what we have with Leishmania species, where we have the A mastigote. However, with Trypanosoma cruzi, the A mastigotes, when they are released from the macrophages, they can switch back to the trypomastigote stage. Okay? And during that phase, if you have another Ludovic ball coming for a blood meal, it's going to pick up that trypomastigote stage. Okay? The parasite has a predilection for cardiac muscles, smooth muscles of the GI, as well as the autonomic ganglia. So how does the patient present? You have two phases. The acute phase, when you have a lot of highly suggestive clinical signs and symptoms, and then the chronic phase. So in the acute phase, depending on where the bite occurred, you can have unilateral ocular swelling, the Romana sign, okay? Or you can have skin lesions, which is referred to as the shagoma, okay? These are all features of acute phase. So here you have the shagoma on the limb, here it's on the cheek, okay? Here it's close to the eye, so it's the Romana sign, unilateral swelling. Other features of the acute phase include systemic features, so there may be fever, malaise, muscle pain, there may be lymph node swellings, myocarditis and pericarditis, particularly in children, as well as meningoencephalitis. Again, this is very common in children. And myocarditis in the acute phase can actually lead to death in some patients. Then we have the chronic phase. Now, the chronic phase is characterized by the involvement of two major organ systems, the cardiovascular as well as the GI. You may also have involvement of the plexus, the GI plexus, but the cardiomyopathy and the GI disorders are the leading presentations when you have chronic Chagas disease. So we talk of Chagasic cardiomyopathy, which occurs in about 30% of infected patients. And what are the symptoms? A patient will present with arrhythmias, right bundle branch block with left anterior fascicular block. These are the classic ECG finding. And it's so classic that I want you to take note of what is written here. If you have a patient coming from any Latin American country and they present with right bundle branch block and left anterior hemiblock on ECG, it is chronic Chagas disease until proven otherwise. Just like we said that if you have somebody returning from a malaria endemic area presenting with fever, it is malaria until proven otherwise. So the same thing holds for chronic Chagas disease. Then you can have patient presenting with dilated cardiomyopathy that leads to heart failure. It's one of the leading causes of dilated cardiomyopathy in Latin America. Then you can have sudden cardiac death, and this is a major cause of death in young adults in these endemic areas. Then you have the Chagasic GI disease, which may present as enlarged esophagus or enlarged loop of bowel. So you can have megaesophagus, which may lead to dysphagia, regurgitation, and aspiration pneumonia. You have megacolon, okay, which may present as constipation Or when it's so large, you can have it twisting on itself. So you can have volvulus, so the patient may present with acute abdomen. And you can also have autonomic neuropathy of the myenteric plexus. Now, this is a barium study of someone with megaesophagus. Okay? So you can see how dilated the esophagus is. Yeah.
Someone presents with GI disease. What should we expect for the history taking? Do we expect chronic Chagas? Do we expect acute?
Chronic.
Chronic.
It's chronic. It's about 10%. Okay. So how do you make a diagnosis? The acute phase, within the first 4 to 8 weeks, this is the period of high level parasitemia. So microscopy can help. The thick or thin blood smear, or if you spin the blood, the buffy coat, you know where the buffy coat is, yeah. From there, you can prepare a smear and you look out for the trypomasticots. You can also use nucleic acid amplification assays if your laboratory has that facility, so you can use PCR. It's one of the most sensitive tests that you can use in acute or congenital cases. Now, you should know that serology is not so helpful within the acute phase because it takes time for the antibody to form. In the chronic phase, or when you have congenital trypanosomiasis, because you know the child has been exposed in utero, so you start counting the time of exposure right from in utero, not after delivery. So that's why we regard it as a chronic presentation. Serology can help, but the WHO says that you need 2 positive serological tests using two different assays. Okay? So you can use ELISA with a lateral flow assay. So those are 2 different platforms. Okay? So you need 2 positive serological tests from different platforms. A single test is not sufficient to make a diagnosis. Is that clear? That's the important message that you should take away. There are times when the 2 tests are discordant. So one was positive, the other was non-reactive. In that case, you have to use a 3rd test. For example, a Western blot, when you now look for specific proteins associated with the parasite. Is that clear? Polymerase chain reaction is not useful for routine chronic diagnosis because it has lower sensitivity. Because in the chronic phase, most of the time the damage is as a result of the patient's immune response. It's no longer the parasite actively dividing within the host cell. So lower sensitivity. However, we can use it to monitor treatment response. For the diagnosis of congenital disease, polymerase chain reaction or microscopic examination of cord blood can assist. Serology can also be used. In this case, you can do a serial follow-up. And if the serology test is still positive after 9 months, then it's telling you that the child has the chronic infection because maternal immunoglobulin G will wane over time. So if the initial assay was showing high immunoglobulin G titers and it was due to the maternal immunoglobulin G, over time the titer will drop. But if the child's immune system has started reacting, then it's going to increase sequentially over time. Do you get the reason why you have to do a serial follow-up? So who do you treat and special consideration? So it's color-coded. You treat all patients when they have acute infection, okay? If you were able to get them within the acute phase. Treat all neonates born to mothers that we know had the disease early in pregnancy. In patients who are going to have immunosuppressive therapy, organ transplant, or patients with acquired immune deficiency syndrome, you can have reactivation of the parasite, so you have to treat. Okay? Children less than 18 years, treat regardless of the phase, whether it's acute or chronic, because you're likely to attain higher cure rate and prevent the cardiomyopathy and the GI pathology associated with chronic infection. Now, there are times when we have adults that have what we call indeterminate status. The laboratory tests are not overtly positive and they're not negative either. So you are not really sure of what you're dealing with. Is there a cross reaction from other parasitic infection, or do you still have that parasitic infection? In that case, you see the color code here is you individualize your treatment. You now have to pay attention to the history. If there is a history of positive exposure, for example, the patient is from a rural area, the patient is living in a house with thatched roof, clay walls, okay? There is a higher risk of being exposed to the vector than somebody in the urban center with nettings, with iron roofing sheets, with cement walls and things like that. So then you have to, take a very good history, ask the patient if the patient agrees to the treatment and things like that. Adults with advanced cardiac lesions, antiparasitic agents may benefit, may not benefit. Different studies, the jury is not really, on the same page. So the jury is still out. It's still debated whether the antiparasitic agent can benefit such patients or not. However, you have to manage symptomatically. So if you have congestive cardiac failure, you have to give diuretics, manage, and things like that. In pregnant women, you don't give antiparasitic agents until after delivery or when the woman has started breastfeeding. When there is severe organ failure, treatment with antiparasitic agents is not indicated. You just manage the complication as the patient presents, okay? So prevention and control. Vector control, like we said, if you control the vector, you're going to control the prevalence and incidence of the parasitic agent. So there are different approaches to this. You can do indoor residual spraying with chemical agents, improvement of the housing facilities, okay? Cement walls, metal roofing. So upgrade the standard of living of the population. Sleeping under insecticide-treated bed nets. All these are examples of vector control. You can also protect yourself by wearing long pants, long sleeve shirts, and things like that to prevent insect bites. For people who donate blood and organs, you can also ensure that you have effective screening methods, particularly in the endemic areas, because remember I told you, it's another way by which the parasitic agent can be transmitted, okay? So make sure that you have effective screening programs in endemic countries. Then serological testing of blood that are donated for transfusion. You should also have organ donor screening before transplantation. In pregnant women, prevention can be achieved through screening, particularly in endemic areas. The test of the neonate's blood for infection, evidence of infection. Treat infected neonates promptly after delivery. Food safety. This applies to travelers to endemic areas. Avoid unpasteurized juice that contains sugarcane. Okay? Proper food handling in endemic areas, and outbreak investigation when you have oral clusters. Surveillance and education can also help. Community awareness of these kissing bugs as vectors of the disease, so when you see them in your housing, you must destroy them. Healthcare workers training, and case notification and contact tracing. Again, similar to leishmaniasis, we do not have any effective vaccines for Chagas disease as at this time. And that's it. Any questions?